Welcome to Chapter 40, entitled Teaching Pharmaceutical Care to Pharmacists and Other Health Professionals. Educating pharmacists about pharmaceutical care begins with reorientating them to the provision of care rather than the supply of a medicine. Then the pharmacist's knowledge and understanding must be developed and tailored to the steps of providing care, assessing the problem, identifying and prioritizing problems, planning the interventions, implementing changes, monitoring, and follow-up. In order to do this, it is necessary to have integrated academic and work-based learning with appropriately qualified and experienced professionals who take on the roles of facilitators, supervisors, mentors, and coaches as necessary. Suitable methods of assessment help the learner to gauge their progression. Next, we will discuss reasoning for pharmaceutical care in practice. Teaching, learning, and applying the concepts of pharmaceutical care to the practicing professional is challenging, but essential to maximizing patient outcomes. One of the first documents to consider pharmaceutical care and pharmacy education was written by a working group of the European Faculties of Pharmacy in 1999. Although the concept of pharmaceutical care has continued to be widely endorsed since this document was published, its inclusion in continuing education, postgraduate qualifications and continuing professional development reflects the different interpretations of pharmaceutical care and the challenges of incorporating it into pharmacy practice. Teaching pharmaceutical care is important and often described as a philosophy, implying it is of fundamental importance, but describing an idea as a philosophy implies it is theoretical and not practical. However, the idea of pharmaceutical care arose as pharmacists thought about how they could provide care with medications, rather than just supplying them. As this pragmatic view is taken, several themes become obvious, namely: 1. Applying the knowledge and skills of the pharmacist to provide care should be central. 2. Pharmaceutical care integrates the relevant knowledge from the patient's medical, family, and social histories in order to identify the factors that influence the patient's use and experience of medications. 3. The development of a therapeutic relationship between the healthcare professional and the patient underpins all of the activities that are needed to provide care. 4. Assuming responsibility for the process of care requires the pharmacist to practice patient-centered care and collaborate with other healthcare providers. For these reasons, it is important that curriculum clearly indicate why pharmaceutical care is needed, what impact it can have on patient outcomes and how it can be effectively employed. Otherwise, its value as a transformative educational idea will be lost. For example, the relationship between pharmaceutical care and other pharmacist activities and responsibilities, such as responding to requests for non-prescription medication, may not addressed, and so limiting the scope and impact of the idea of pharmaceutical care. Furthermore, as healthcare changes, new approaches to education and care delivery are needed. In education and healthcare, understanding and employing these concepts are essential because as the development of any healthcare professional progresses from novice to expert, it requires growth in knowledge, skills, competence, judgment, collaboration, and leadership. Pharmacy educators must be able to clearly articulate these concepts when teaching pharmaceutical care so that pharmacists can optimize patient outcomes by appropriately managing medication use. If a formal qualification is to be awarded to certify the pharmacist for a specific type of practice, then the requirements and standards of the practice will also have to be factored into the description, structure, and assessment methods used in the program. Unlike undergraduate students, pharmacists are mature and adult learners with a body of experience and expertise to draw upon. They may be engaging with a formal pharmaceutical care education programs as part of their continuing professional development, but they could also be taking an active learning approach and changing their practice model or introducing new services. This relates both to professional requirements and obligations as well as a need to skill up in order to enable a new output or service-related aspect. Many pharmacy settings enforce compulsory CPD that seeks to ensure fitness to practice and protects that patient, but in addition there may be requirements to demonstrate a certain competence, such as following deregistration of medicines for pharmacists to provide over-the-counter, in order to perform that role. The ultimate goal of teaching pharmaceutical care to pharmacists is to optimize patient drug therapy. That is to ensure that pharmacists gain and improve skills on diagnosing and resolving drug-related problems in various patient populations. In order to be able to diagnose and resolve drug therapy problems, the teaching program should empower pharmacist staff with a set of skills, knowledge, and behaviors, in other words competence. For optimal pharmaceutical care, first, pharmacists should ensure that their knowledge and understanding enable them to make accurate, appropriate and timely clinical decisions. Second, pharmacists should be taught on how to perform certain skills such as undertaking a medication history and reviews with clinical reasoning to optimize drug therapy through good communication. Thirdly, the pharmacist needs to have developed behaviors and exhibit attitudes towards patients and members of the healthcare team towards achieving the full complement of pharmaceutical care. We will now look at pharmacists. Education for pharmaceutical care necessitates reorienting pharmacists' roles and responsibilities from suppliers of medication to providers of care. Pharmacists in practice may take a traditional approach and start with the medication and work backwards to considering the patient's condition and finally to the patient themselves. Typically, task-oriented procedures and protocols support the use of rapid screening processes to identify problems associated with a prescription, a non-prescription request, or a request for advice about symptoms. While these provide structure and enable quality assurance to be carried out and are a reasonable approach to managing the workflow in a pharmacy, other skills and procedures are required in order to provide care. Pharmaceutical care is similar to task-oriented procedures as both are logically structured and systematic, but differs because it is outcome-oriented, holistic, patient-centered, and interprofessional. As some currently practicing pharmacists may not have received formal instruction in the concepts of pharmaceutical care in their undergraduate curriculum, these individuals need to be educated so that they can provide patient-centered services in their respective practice setting. Central to the ability in providing pharmaceutical care is understanding the 6 stages of the care cycle: assessing the problem, identifying and prioritizing problems, planning the interventions, implementing changes, monitoring and follow-up. This complex process has been a part of the education of other healthcare professionals for many years, and requires the combination of knowledge, skills, and judgment to effectively execute. Educating the practicing pharmacist creates unique challenges not often faced in other educational settings, and if work-based learning is to be effective, it will require commitment and planning. To learn and employ the principles of pharmaceutical care, there needs to be some reconstruction and reorganization of knowledge, modification of perspective, and development of new processes. Some of the skills may not be familiar to a pharmacist. For example, reflection and reflective practice has long been used in nursing education, but may seem an unusual tool to some pharmacists. Communication skills and self-directed learning of the mature learner to be refreshed in a way that engages the practicing professional, and subsequently the teacher assumes the role of facilitator, advisor, mentor, and coach. Furthermore, the educational setting should involve traditional didactic environments coupled with patient care settings, utilizing simulated and real-life patients for instruction and assessment. Interprofessional educational opportunities should be encouraged to allow for a more patient-centered learning approach, diverse and comprehensive care plan, and develop interprofessional trust and respect. The need for a competency framework depends upon the educational setting, instructional methods, and whether individual behaviors or global assessment of performance is being evaluated. A list of suggested educational methods for pharmacists can be found in Table 40.1. Pause the video and carefully scrutinize Table 40.1 summarizing suggested components of a pharmaceutical care education program before advancing to the next slide. Pause the video and carefully scrutinize Table 40.1 summarizing suggested components of a pharmaceutical care education program before advancing to the next slide. We will now look at a programmatic approach to pharmaceutical care. Let's begin with education. Education of practitioners in pharmaceutical care should therefore be systematic with clear exit outcomes based on the individual and/or institutional needs. In this section, we propose and discuss the monitoring, training, and planning, abbreviated as MTP, model for effective teaching on pharmaceutical care to pharmacy staff. The first step is to monitor and evaluate the current practices of pharmaceutical care in any given practice setting amongst the various pharmacy personnel present. This will help in the identification and quantification of the teaching needs. In addition, the assessment of the training needs provides a baseline for monitoring implementation of a particular teaching program. Once the training needs have been identified, for example, through a rigorous external needs assessment or through individual self-assessment such as in the use of a learning diary, training curricula or teaching or training guides should be developed to implement teaching strategies that would address competence through the knowledge, skills, and/or behavior gaps in pharmaceutical care. Different modes of training, resources, methods, and approaches may be adapted to closing the specific pharmaceutical care gap or gaps identified. Once the teaching has been implemented, a plan should be put in place to demonstrate that there is improvement in the practice of pharmaceutical care. For example, this could be reported by the individuals concerned or through external evaluation of the training program after some time has elapsed by means of valid specific and structured assessment tools. The plan should have clear goals of what is expected to improve within a specified timeline and should also enable the pharmacist access to the most appropriate resources as well as resourceful persons, such as learning or practice mentors, to achieve the intended outcomes. Next we will discuss pragmatic approaches to pharmaceutical care education. One core aspect of a teaching curriculum or guide is the unit standards, which express the extent and depth of learning. The unit standards are key elements in the training of pharmaceutical care to pharmacist staff members. Unit standards indicate and describe the competencies to be acquired and include a defined set of knowledge, skills, and behaviors. Two main unit standards are assessing and resolving drug therapy problems. Overall, this requires the development of skills in clinical reasoning as well as interprofessional practice. Another important unit standard is one aimed at developing the clinical approach of pharmacists. This unit standard would focus on imparting skills such as handling clinical information, that is clinical records, medical notes, drug administration charts, common medical abbreviations, and interpretation of clinical laboratory tests as well as patients' vital signs. In this approach, the education of pharmaceutical care amongst pharmacists is iterative. Next we will discuss training on the assessment of drug therapy problems. Box 40.1 Knowledge of drug therapy problems. The pharmacist staff should be knowledgeable of the 8 drug therapy problems in general, that are as listed below. 1. Adverse drug reactions. 2. Choice of therapy. 3. Inappropriate indications, such as drugs without indications and indications without drugs. 4. Drug-drug interactions. And 5. Inappropriate dosage adjustment, for example, underdose or overdose or duplications. 6. Compliance to therapy. The pharmacist should be trained on basic concepts on how to assess and resolve each of the above drug therapy problems and medication errors. In this section, we discuss in detail what aspects should be emphasized in the general teaching on medication errors and drug therapy problems. In addition, the pharmacist should be trained to obtain a medication history, undertake medication reconciliation, and perform an appropriate type of medication review to identify the drug therapy problems. It is important that each pharmacist knows how to take a medication history. This training should ideally be done at the patient bedside, with support from a senior pharmacist mentor, and a standardized protocol for taking history should be used. The teaching of medication history should focus on sources of medication history, how to effectively carry out the medication history interview and documentation of a complete and accurate medication history as part of the patient's clinical record. Training on medication history should be followed by a teaching on medicines reconciliation, where the pharmacists are taught on techniques to identify discrepancies in the documented medication history and the patient's current therapy. Medicines reconciliation should be undertaken preferably in patients on high-risk medicines, and/or in busy environments or transitioning between health facilities and practitioners. The teaching of medication reconciliation should emphasize errors of duplication, omission, commission, and transcribing. Pharmacists should also be taught skills on the review of drug therapy as a whole for its appropriateness, safety, and cost-effectiveness. The need for subjective patient data as well as objective patient data should be emphasized in the identification and prioritization of the drug therapy problems. The pharmacist should be introduced to the different levels of a medication review, that is level 1 to level 3, from a review of a prescription to performing a thorough review of the clinical case including the patient and treatment. See also Chapter 6. The teaching of medication review may require emphasizing training on the patient behaviors, disease, pathophysiology, and the pharmacotherapy as well as clinical reasoning. The pharmacist should be taught the clinical presentation of the diseases and the diagnostic criteria used to identify diseases as well as their appropriate drug therapy. Training should also focus on the pathophysiology of 5 major categories of disease states, including metabolic, inflammatory, neoplastic, degenerative, and congenital, hereditary disorders. For each patient case, the pharmacist should review the clinical presentation, lesions, etiology, and pathogenesis of each disease state. In addition, for each disease state, the pharmacist should be familiar with the pharmacotherapy including the drug classes of choice, the rationale of use, adverse effects and mechanisms, and unique pharmacokinetic aspects of the drugs. This basic knowledge of pathophysiology and pharmacotherapy should be reviewed by the pharmacist and verified and validated by senior pharmacists and fellow pharmacists before pharmaceutical interventions are made and communicated to other members of the multidisciplinary healthcare team. Once the pharmacist demonstrates competency in obtaining medication histories, undertaking medicines reconciliation, and medication reviews, the pharmacist should be taught how to develop and implement a pharmaceutical care plan, as will be discussed in the next sections. Box 40.2 Awareness of common medication errors. The pharmacist should be aware of the common medication errors that may lead to drug therapy-related problems. These errors include the following. 1. Duplication of medication. 2. Omission of a medication. 3. Commission errors. And 4. Transcribing errors. Next we will discuss resolving drug therapy problems. The pharmacist should be taught on how to collate subjective and objective data to identify and prioritize drug therapy problems, and ultimately how to intervene appropriately to ensure the best desired outcome for the patient. The pharmacist should be able to use criteria and evidence to justify the potential and/or actual occurrence of drug therapy problems and also estimate the risk or contribution of the drug therapy to the patient's problem. This requires clinical reasoning with knowledge of pharmacotherapy and pathophysiology and well as patient assessment. Pharmacist staff should be encouraged to collaborate with other members of the healthcare team, interprofessionalism, to validate the drug therapy problems that they may have identified. Pharmacists should be taught on skills of interprofessional collaboration and practice that include, for example, effective communication strategies in a specific cultural context, and assertiveness. This should subsequently lead to training on the development and implementation of a pharmaceutical care plan. It is advised that a standard tool for a care plan should be used during training of pharmacist staff. This should have aspects of the priority problems, the goals of therapy, the options for therapy, the most appropriate interventions for the patient, and the plan to communicate the intervention to the health team as well as monitoring the goals of therapy. Specific emphasis in the plan is the development of SMART goals of therapy, which are specific, measurable, achievable, realistic, and timely, and communication to the patient and the rest of the healthcare team as well as documentation. The pharmacist should be taught on how to use evidence of up-to-date data development and interpretation to optimally develop and implement a care plan. Pharmacists with adequate knowledge of pharmaceutical care planning should regularly attend clinical rounds to advise on therapeutic decision-making in real time and further develop their pharmacotherapeutic relationships with patients and other clinicians. Next we will look at the clinical pharmacy reasoning toolkit. Most importantly, pharmacists should be taught to adopt and apply a clinical reasoning approach. The SOAP approach, which stands for Subjective, Objective, Assessment, and Plan, is the most commonly used clinical reasoning tool by healthcare workers. The pharmacist can be taught on how to use the SOAP approach to identify and resolve drug therapy problems and also collaborate with other team members to best identify the main health problem. This will involve engaging in the process to validate the current subjective and objective presentation of the health problem with relevant and appropriate evidence in literature and/or criteria and methods. This may be aggregated into local, national, or international clinical treatment guidelines, for example. The key steps in clinical pharmacy reasoning are to do the following. 1. Identify the subjective and objective data from the case. 2. Use appropriate and valid evidence to associate the subjective and objective data with a medical, that is disease, pharmaceutical, that is drug therapy, and/or nursing, that is psychosocial, problem. 3. Check the relationship between the drug therapy problems and the medical and/or nursing problem in order to establish and validate the current drug therapy problem or problems, and prioritize the health problems. Subsequently, a care plan should be developed and implemented based on the drug therapy problem. And now we will consider monitoring of changes in practice. In order to monitor changes in practice as an impact of pharmaceutical care training on practice, professional audits of practice should be undertaken. An audit of both pharmaceutical outputs, that is, self-reported pharmaceutical interventions, and patient outcomes associated with the interventions can be carried out. This would require that pharmacists document their interventions along with the corresponding patient outcomes. These audits can reveal the most common interventions made and at what point of the patient journey, admission, in-hospital patient stay, and discharge, the interventions are made. Feedback can be sought from the wider interprofessional team in a systematic manner on the pharmacist's role and input. In addition, research can also be undertaken as a more substantive approach to measuring impact and monitoring changes in practice to inform any change in education. The content and focus of the next training should be informed by results of professional audits, feedback, and research undertaken to monitor the impact of initial training on practice. Next we will look at other healthcare professionals. Other healthcare professionals may arguably better understand the 6 stages of the care cycle and have a defined scope of practice. Therefore, the items described in Table 40.1, for example, are not new. It is the idea that the cycle may be applied to medication-related problems that is novel. They may be learning about pharmaceutical care for one of 2 reasons. 1. To understand what pharmacists mean and intend by pharmaceutical care. And 2. To improve the outcome of use of medication by their patients. The material presented in Table 40.2 is relevant for both reasons and will help them to review their perspective of healthcare and inform them about the pharmacist's role, how patients view and use medications, and how to improve medication usage to maximize patient-oriented outcomes. Teaching pharmaceutical care to other health professionals requires a range of skills and mixture of styles from facilitator to expert, and from mentor to coach. As in the case of teaching pharmacists, if a formal qualification to certify the recipient to practice is to be provided, the details of the requirements and standards will fundamentally influence both what is taught and learnt and how it is assessed. Pause the video and carefully scrutinize Table 40.2 summarizing examples of assessment tools for pharmaceutical care in practice before advancing to the next slide. And now we will discuss the assessment of learning in practice. Assessments used to measure and evaluate pharmaceutical care learning in undergraduate and pre-service are well described in Chapter 39 and include many tools that can also be applied for learning in practice and amongst practicing pharmacists. The focus of competency-based assessment becomes even more important. However, as pharmacist learners will need to demonstrate improvement in competence in their practice. This can be broken down, for example, by assessing knowledge through multiple-choice question, abbreviated as MCQ, style assessment that can be orientated in different ways, true or false responses, single, multiple answer formats, extended MCQs, etc. But there are a number of valid methods for assessing learning in practice that give a 360 degrees evaluation of the learner. The challenge will always be to assess learning as close to the intended competency as possible, and some assessments should be carried in the learner's practice. For example, the clinical evaluation exercise, abbreviated as CEX, can be applied in the clinical practice setting with the pharmacist being assessed in their real interaction with a patient and being assessed for their applied clinical knowledge, attitudes, and behavior. The outcome of this type of assessment shifts from a graduated score, e.g., percentage correct, to a system more rational to the setting, such as, above expectations, meets expectations or does not meet expectations, or, competent or not yet competent. Obviously, this assessment cannot be systematically reproduced learner to learner, but over the course of time, the learner should start to develop, show improvement in their assessment, and consistently demonstrate competence in most situations they are presented with. Directly observed practice, abbreviated as DOP, similar to the OSATS in Chapter 39, can be applied in more technical areas of practice, for example, aseptic, sterile production of medicines or quality assurance settings. Otherwise, the learner can be afforded more time for reflection and peer review, such as in the case-based discussion, abbreviated as CBD, that is retrospective in nature, whereby the learner and assessor discuss the course of action and intervention of pharmaceutical care that has already taken place between the learner and patient. A broader peer review assessment tool exists in the peer assessment tool, abbreviated as PAT, that combines the feedback from a range of interprofessional clinical colleagues that work alongside or practice with the learner. This feedback is systematically gathered and is measured against the learner's self-assessment against the same criteria of various domains of practice, and can also be compared against a group mean of learners undertaking the same education in pharmaceutical care. These examples of assessment tools, alongside the OSCE, see also Section 39.3.3, can be used in formative and summative assessment and give a broad picture of the competence of the learner as demonstrated in practice settings, simulated practice, self and peer assessment that reflect the competence. Assessment and examples of practice and learning can be brought together in a portfolio of practice, such as those used in continuous professional development. Learners can then be signed off in their assessment of practice through their portfolios before progressing in their studies. As a practical tool, below we give some scenarios that trainers or instructors may encounter when formulating new learning. Let's now discuss Scenario 1. You work as a trainer for the provider of continuing professional development, or continuing education, for community pharmacists and pharmacy staff. You are new to the role and have been tasked with freshening up the learning approach. This will involve a better understanding of the learning needs and how the implementation of learning will actually impact on improving the competence of the clients. What initial questions do you think you need to ask? What approach would you use to identify the learning needs in the target population? How do you think you could demonstrate or evaluate the impact of your learning on competence? Do you think it is important to evaluate competence as an outcome? Next we will discuss Scenario 2. You are a clinical instructor employed in the local teaching hospital under the Training and Education Division. You have to deal with a seemingly constant flow of undergraduate pharmacy students on placements in your hospital, new internship, pre-registration graduates of pharmacy, and pharmacy residents for whom you have to tailor training at the appropriate level and in the right setting. Ultimately, what do you think is your first duty of care? Hint: in relation to medical ethics, and what tools can you employ or measures you can put in place to ensure this? How will the training you provide for the various groups differ in terms of their orientation, depth of training, supervision, and responsibilities given to patient care? Sketch out some learning strategies for each of the pharmacy learner groups described above. How would you approach their training? Thank you.